behalf of the California Institute for Mental Health, in collaboration with the Alcohol and Drug Policy Institute and the Integrated Behavioral Health Project, we'd like to welcome you to the fourth of a six-part webinar series, Integrating Primary Care, Mental Health, and Substance Use Services. The goal of this webinar series is to provide information on critical policy, design, financing, and practice issues related to integrated care from the California and national perspective. The webinars will cover best practices and emerging practices in the field with presentations from state and national advocates, researchers, and practitioners. These webinars are free and open to all and are held from 12 to 1:30 p.m. on the dates indicated in the schedule, which is posted on the CIMH website. To view the schedule or to register for future webinars, please go to the CIMH online learning link on the CIMH website. Please note that you must register online for each webinar you wish to attend. Webinars will be recorded and posted on the CIMH Integration Initiatives webpage following each event. I will cover this information again at the end of the presentation. Again, good afternoon. My name is Lori Alexander. I'm a behavioral health consultant with CIMH and the facilitator and one of the presenters for today's webinar. I'm honored to be doing this webinar with such an outstanding group of panelists. Brenda Goldstein is the Psychosocial Services Director at Lifelong Medical Care, a community health center serving Berkeley and Oakland, California. She has worked for more than 25 years to improve access to care for underserved populations. Ms. Goldstein has fostered numerous partnerships with public and community agencies to create medical, mental health, and social services systems of care for homeless, mentally ill, and substance-using individuals. This includes provision of on-site services at permanent supportive housing sites, development of a system of care for frequent users of emergency services, and the integration of SSI advocacy activities in the primary care setting. Bill Schlesinger is the Chief Executive Officer of Project Vita Health Center in El Paso, Texas. He is also co-director of Project Vita, a Presbyterian-sponsored community services entity, along with his wife, Carol. He has been part of the development of multidisciplinary community-oriented approaches, including housing, economic development, education, and social services to improve community wellness in addition to integrated healthcare systems in El Paso, Texas. His doctoral degree is in ministry, and he is also an ordained Presbyterian pastor. Rachel V. Quintanilla, LMSW, has been the care manager for Project Vita Health Center since 2006. Prior to joining Project Vita, Ms. Quintanilla worked with Family Service of El Paso, a local nonprofit counseling center, providing psychotherapy to individuals, couples, and families. She earned a Bachelor's of Arts in Psychology from the University of Texas at El Paso and a Master's in Social Work from New Mexico State University. She first worked with Project Vita as an AmeriCorps volunteer, working with the Gang Task Force and El Paso Mental Health and Mental Retardation Adolescents. And finally, let me say just a little bit about myself. My name is Lori Alexander again. I'm a clinical psychologist and a behavioral health consultant specializing in integrated healthcare. Prior to consulting, I was a program officer at the Hog Foundation for Mental Health in Texas, where I oversaw the foundation's integrated healthcare. So, before we get started, a brief word on how today's webinar is structured. I'm going to start off by giving a brief overview of the topic, and then our presenters from Lifelong and Project Vita will introduce their organization. Next, we will explore key aspects of the presenters' integration work through a structured dialogue, and then we will end with about 15 minutes for audience questions. Due to the limited time available and the large number of audience members, we will only be able to take written questions for the presenters. So to send in a written question at any point during the webinar, simply type your question in the dialog box and click Submit. We've had a wonderful response to this webinar with well over 200 participants signing up, so we apologize that we may not be able to get to all of your questions during the webinar. Following this presentation, we will create an FAQ bank on the CIMH website to address as many of your questions as possible. So that's it for background. Thank you all again for joining us today, and now let's begin our presentation on addressing mental health issues in primary care. Next slide, please. So I'm going to be starting up at a pretty high level with the first question being, so why do we care about integrating physical and behavioral health care? Next slide. When you think about why you want to look at this issue of integration, think where a lot of people start is by looking at where people seek mental health care, and that's really in the primary care setting. Research has shown that most people seek help for mental health problems in primary care, and in fact, about half of all care for common psychiatric disorders happens in primary care settings. Populations of color are even more likely to seek or receive care in primary care than in specialty mental health. Next slide, please. In terms of the kinds of problems that we see in primary care, really it's a range of things. You see a full range of mild to moderate psychiatric disorders, the most common of which in adults are anxiety, depression, substance use. And then when you look at children, it tends to be anxiety, ADHD, and behavioral problems. What I think is really striking about this is that it's mostly mild to moderate psychiatric disorders, which tells us there's a real opportunity here to intervene early to prevent disorders from becoming something that's worse, something that's more disabling, to intervene early and make sure that people get the help they need. The other thing that we see quite a lot of in primary care settings is people with common medical disorders who also have mental health problems. In fact, the two tend to go along together quite commonly. So, for example, diabetes, heart disease, and asthma all have very high comorbidities with depression. The issue with this is that we see that if you don't treat both the depression and that chronic medical condition, you're going to have worse outcomes and higher costs. And so it's absolutely critical that you address both sets of problems. Next slide, please. So why do people go to primary care for mental health conditions? There are a number of reasons for that. The first tends to be that a lot of folks are uninsured or underinsured for mental health coverage, and so going to especially mental health centers just may not be an option. Along those lines, a lot of times people have pretty limited access to public mental health services. So depending on how the state limits access to those services, for example, by different diagnoses, different kinds of criteria like that, people may literally not have access to public services. Another issue, I think, is a very large one, is that cultural beliefs and attitudes can also get in the way of people going to specialty mental health care. So that's the issue of stigma, that a lot of people feel that there's something shameful, something dishonorable about saying that you have a mental health problem, so they may be more likely to raise that with a primary care provider than going to a psychologist or a social worker. And then finally, I know this is a big issue in large parts of the state of California, the availability of especially mental health services can be pretty limited, and that's especially true in rural areas. Next slide, please. So we know lots of people are going to the primary care setting to seek help for mental health problems. So what kind of care are they getting? It's not very good by and large. Usual care for mental health problems in the primary care setting tends to be pretty poor, unfortunately. A lot of times mental health problems go undetected and untreated. In fact, research has shown that it's about half of mental health problems go undetected. And when primary care providers do detect mental health problems, they tend to undertreat them. So meaning that they don't give them enough treatment in order to actually get better. So for example, someone may be parked on a very low dose of an antidepressant for years, despite the fact that they're really not showing improvement on that. And this is really especially a problem for populations of color, children and adolescents, older adults, the uninsured, and low-income patients. With all of those groups, we find that they're especially unlikely to receive adequate care for mental health problems in the primary care setting. Next, please. So coming back to integrated healthcare, what we really want to see here is the opportunity to try to address these problems, but challenges get in the way. So why is it so difficult to do mental health treatment in primary care? We see challenges at all different levels in the system, basically. At the patient level or the client level, there can be issues with people being unwilling to discuss mental health problems or to participate in mental health treatment due to stigma. At the primary care provider level, there can also be issues around stigma. Primary care providers feeling like they shouldn't have to address mental health problems, shouldn't have to treat them. They may feel like they don't have enough training or enough time to address those problems. And there can be especially a lot of fears around prescribing for children. because of issues around, suicidality, homicidality, et cetera. And then at the system level, we see a number of potential challenges related to limited insurance benefits for mental health conditions. Of course, with disparity, we hope that that all will be addressed. And also in terms of primary care providers' ability to bill for mental health services. It's important to note that exactly what those problems are really do vary by state and by payer. And so I think part of what's going to be interesting about this call today is we have Brenda Goldstein from Lifelong, Bill Schlesinger and Rachel Quintanilla from Project Vita. One is a California site, one is a Texas site. So they've really encountered some similar issues in this regard, but also some different ones. So integrated care. The key thing here is that we have an opportunity by addressing some of these problems to reach groups who cannot or will not access specialty care, and to prevent mental disorders, and to intervene early so that they do not become worse. So that's really kind of what brings us to this point. So the issue is then, if we have this great opportunity, what can we do to improve mental health care in primary care settings? There are a number of things that people have tried that are, I think, helpful, but I would say are not sufficient, meaning that these are helpful elements of an integrated approach, but if you do just one of these, you're not going to get extremely far on their own. Where most people tend to start is by thinking about physician training. So the idea is, okay, so if physicians are so poor at detecting and treating mental health problems, let's just train them up so that they get better at doing that. Unfortunately, we found there's a rich research, body of research, really it's 30 years old at this point, maybe 40, showing that just training alone is not going to impact patient outcomes. Training just doesn't seem to stick. If you just send someone even away for like a week-long CME course on mental health problems in the primary care setting, it's just not enough to change how physicians do their practice. You really need to support them over time. So where people often go next is saying, well, let's just support them through screening. Let's give physicians some tools to identify those mental health problems so that they know what's going on in their practice. So there are all sorts of screening tools that have been developed. The research shows that while that is very important and very helpful for identifying people, screening alone does not change outcomes either. You really have to have some treatment in place where if you screen someone, find that they have depression or anxiety, you need to be able to do something with those problems. You need to be able to treat them effectively in order to change outcomes. I know that sounds kind of obvious, but I think it's worth noting because a lot of times people really will just go to the screening and think if we just identify this problem, then we're going to just somehow be able to treat it appropriately. So I think the next place where people go after there is, okay, so if you tell me that, I can't screen my physicians adequately and screening alone isn't going to really help, how about I just refer out all these folks to the people who actually know how to do this screening care? There's a lot of issues around referrals as well, unfortunately. The main one of which is that about half the time, people do not follow up with referrals. So referrals in and of themselves mostly just don't kind of work. People don't end up making it to, especially mental health providers, to get the kind of care that they need. And if you remember the earlier slide that I went through in terms of why people go to primary care instead of specialty settings, I think you'll also see that there may be nobody to refer to. So, a primary care provider may be all gung-ho about just referring out the people who need especially mental health care, but there may be literally no place to send them. So that's an issue with referrals. And then the last strategy that a lot of people have tried, and again, I think is helpful and important but not sufficient, is co-location of services. So the idea with co-location is that if you have a primary care practice, you take a specialty mental health provider, a social worker, a psychologist, a psychiatrist, and you plop them down in the primary care setting. This is a good thing. We do want co-location of these providers, but what the research and practice have shown is that simply co-locating those specialty providers does not mean that they're going to do any better job of collaborating with each other, communicating about patients, talking together about how people need to be treated, the kinds of treatment planning that needs to be happening, the follow-up, etc. Simply co-locating people alone will not change outcomes. So all of these I think we can see as very helpful elements, things that are important to do, but by themselves are not going to change the outcomes that we see for patients. Next slide, please. Now this is in terms, again, I want to emphasize we're talking about the research base, right? And so, you know, there's all these other things that are happening out there in the world that are more practice-based kind of evidence. But what I'm really talking about here is the research evidence base. And when you look at all the research that we have, the strongest evidence base is for an approach called collaborative care. There's been over 25 years of research now on collaborative care, over 38 randomized controlled trials, including IMPACT, which is one of the focuses for today. I want to emphasize that IMPACT is one implementation of the collaborative care model. So when you hear people talk about collaborative care, you hear people talk about IMPACT. IMPACT is a version of collaborative care. All collaborative care approaches really stem from Ed Wagner's chronic care model, which was something that he developed in group health in Seattle a while back now, decades ago, with the idea that you need to do something in order to better organize care for chronic conditions that need to be followed over time. If you're not familiar with Wagner's chronic care model, we have a link there in the slide so that you can go and get more information about it. So let's talk a little bit about what collaborative care is. Basically, I think it can be seen as a set of basic principles and core components. The thing that I think is really appealing about this is that if you have those basic principles, you have those core components, you can really tweak them, organize them, put them together however you need to based on your financial situation, your workforce resources, whatever your constraints are as a setting, it's adaptable. So the next slide, please. Let's talk about what those key components are for collaborative care. There has been, through the research, identified 3 active ingredients for collaborative care. The first one is care management. Now, care management is different from case management and social service provision or connections that you see in both mental health and medical settings. What care management does is really it's a function by which you are educating and empowering patients, but you're also following them over the course of treatment to be sure that they are following through with their treatment regimen and responding as they should be. So that if they're not, that care manager can identify that problem right away and jump on it instead of people just being allowed to fall through the cracks. Second core ingredient is evidence-based treatment. So this would be doing effective medication management. So that means not just parking someone on a low dose of antidepressants for 5 years, but actually, putting them on an effective medication if they're not responding, increasing the dose or changing them to a different medication. So actively managing the medication and making sure that it's having an impact. The other approach, of course, is counseling and psychotherapy. We have a number of excellent evidence-based treatments now that are psychotherapy-based, such as cognitive behavioral therapy, problem-solving therapy, things like that. All of these things that can be done in the primary care setting and are a key component of collaborative care. And then finally, psychiatric consultation. The idea with this is that primary care really needs access to that psychiatric expertise, if only in small doses, so that if a patient is not improving as expected, you can get that expert psychiatrist in there to provide consultation, suggesting how to proceed. So it's not just left to the primary care provider on his or her own to try and struggle with what to do next. Next slide, please. So those are some of the active ingredients of collaborative care. I want to talk a little bit about impact. This is a model that I think a lot of people have heard about. It's really the largest implementation of collaborative care that's been done in a research setting. Impact had over 1,800 participants in 18 clinics across 5 states. And what they did in the impact model, it was an implementation of collaborative care, and what they really saw is that there were 2 key processes that they were adding to a primary care practice. The first one was systematic diagnosis and outcome tracking. So there were tools that were in place to, 1, identify people who had mental health problems. Well, in this case, it was actually just depression that they were looking at. And then tools for tracking their response to treatment. So that was the outcome. So since it was focused on depression, there was the tool, the PHQ-9, that was used to diagnose and then track outcomes. The second key process is called stepped care. The principle of stepped care is that you are actively monitoring people's response to treatment, and if they do not seem to be responding to treatment, you change course. So you up the dose of something, you add psychotherapy to a patient, whatever it is. You don't just park someone on one level of treatment. If they're not responding, you actively address that and do something more, something different, something new. So those are the two key processes that were added, and then there's also two key team members that were added. First is the care manager, and I've talked a little bit about the care manager, and we have on the call today Rachel Quintanilla, who is the care manager, so she'll be able to talk a little bit more about that role. So that's the person who's doing the patient education, empowerment, and making sure that people don't fall through the tracks. So really tracking them through their course of treatment. And then the consulting psychiatrist, who's providing that expertise around patients who are not responding to care, who need a little bit of extra help. Next slide, please. So impact, it was a phenomenally well done study, and I think that's why you hear it talked about all the time. They have very good outcomes from it. We found that it doubled the effectiveness of depression care. It improved physical functioning. They were able to document long-term cost savings, which as most of you know, I'm sure it can be pretty hard to do. And I think one thing that was particularly compelling about it was that they found that the greatest gains were found in the most disadvantaged population. So that's compelling. Next slide, please. Impact was done. People were so impressed with how that was done. I'm sorry, next slide, please. People were so impressed with the outcomes from that that there were actually funds that were dedicated to helping impact being implemented in the real world. So this impact came out of the University of Washington, and now through the University of Washington there is the AIM Center. And then, Sarah, it looks like the slide is not advancing. If you can do that, thank you. The AIM Center there at the University of Washington is a research and training center that has really been charged with trying to disseminate impact nationwide. And so they provide training and consultation. And really, it's an excellent resource that I would encourage you to take a look at. They have a lot of nice training tools on there that are available for free, and also some nice planning tools that can be helpful for organizations that are looking at doing integrated care or collaborative care. Next slide, please. So one last thing I would say, kind of, again, thinking about how you do this in the real world, talk with the people who've done impact, and Dr. Jürgen Unitzer, who's at University of Washington, is really the lead principal investigator on that study. What he talks about now is, reflecting on the model that he tested, and now having done training and consultation on this for multiple years, that he feels like really when you take those basic core functions that need to be done in an integrated setting, instead of thinking about mapping those onto a kind of rigid structure, that you have to have a care manager with certain credentials, or you have to have X number of hours of a psychiatrist on staff or something like that. What he really recommends now, based on all this experience he has under his belt, is that you look at the core functions and you map them onto the resources that you have or that you're able to get, so that you have really a practical implementation. It's not some pie-in-the-sky kind of thing that people can't do, but he's saying if you look at what needs to be done, you look at the resources you have, you should be able to find ways to match them up together. And he has a nice tool on that AIM Center website, and you'll see that, that link on the slide that shows kind of how to walk through that. The thing that I really like about that, again, is that it's not talking about a rigid model for doing this, but breaks it down to key elements that just about any site should be able to figure out how to do given the resources that they have. So let's move on then. Next slide, please, to thinking a little bit more about what integration looks like in the real world. I've just given you a brief overview of kind of what we know from the research evidence, but of course, we all operate in the real world, and let's talk a little bit about what this looks like on the ground. We have two just wonderful organizations that are represented today. We're going to hear from them next, just a little bit of background in terms of their program, and then we're going to get into that structured dialogue we talked about. Brenda?
Thank you for having me today. My name is Brenda Goldstein. I'm Director of Psychosocial Services with Lifelong Medical Care. And Lifelong is a community health center, federally qualified health center, serving primarily Oakland and Berkeley. Next slide, please. We have 6 primary care clinics, 2 adult day health centers, a dental clinic, a large supportive housing program, and a program to provide wraparound services for frequent users of emergency departments at 3 large urban hospitals. We serve slightly more than 20,000 low-income patients a year, and about 75% of them are at or below 100% of the federal poverty level. And you can see on the slide that the majority of our patients are either on Medi-Cal or uninsured. And we have, for many years, been focusing on integrating primary care and behavioral health at all 6 of our primary care clinics. Next slide, please. We have several special populations that we work with and that have really contributed to the development of our integrated model. Our first clinic was a clinic that was developed specifically for older adults. It's called the Over 60 Health Center, and was developed really primarily for serving folks in order to be able to let them maintain their independence and stay at home. We also, as I mentioned, serve frequent users of hospital emergency departments. We serve folks who are living on the streets, as well as formerly homeless individuals who are now residents of permanent supportive housing. We have programs for physically, mentally ill, and substance using individuals, disability focused. And we also have primary care providers who are embedded in assertive community treatment teams, working with community-based organizations to serve people who are seriously mentally ill. And then we have a program called Centering Pregnancy and Centering Parenting that is focused on doing long-term group visits for pregnant women and families. And all of these have integrated mental health primary care components. Next slide, please. Just very briefly, you can see our ethnic breakdown, which is you'll see is quite different from that of Project Vita. We serve 38% African American clients, and then 20% Caucasian, 17% Latino, and then the remainder are mixture of Asian, Native American, and unreported. So we have a very diverse patient population, and the majority of folks are living in urban low-income area. And then finally, just to give some background on the age of our population and insurance coverage, the majority of our folks are between 25 and 54 years old, though you can see we have a significant number of people who are 65 or older, 20% of our population. We do also serve young families and children, and we have 2 of our sites that are family practice clinics. And again, primarily Medicare, Medi-Cal, and uninsured. Over to you, Bill.
Thanks very much, Brenda. And now we'll hear from Bill and Rachel from Project Vita.
Hi, we're delighted to be with you all. Project Vita was originally started in 1990 as a community center with the intent to identify a neighborhood's sense of direction, vision, even though the neighborhood had never really articulated that. So we spent about 2 years talking with the neighborhood and came out of that with a plan that included housing, access to health care, early childhood development, after-school activities, and about 4 years ago in a community congress, we added economic development, and we've got a fairly strong microenterprise technical assistance program. Next slide. That's Project Vita means worth life in Spanish for those of you who haven't tracked that language recently. And this is a picture of our central facility. About 200 yards behind that building is the border with Juarez. Next slide. The focus of our area is almost entirely Hispanic, and that's in our population in the clinic. We're about 70% in the city itself and in the county. We've recently, relatively recently for us, become an FQHC. We're in a very high area of professional shortage, particularly in mental health services. Next slide. It's a very isolated area in El Paso. We're about 300 miles from the nearest city in any direction. North is Albuquerque, west is Tucson, east is San Antonio, and south is, what's south? Mexico. Anyway, it's a long way if you get past Juarez to anything in Mexico. So we've been spreading out a little bit. We have two other larger community health centers in our area. We're in South Central, Northeast. We also have a dental clinic in Northeast. We're in Far East in what's called a colonia. That's an unregulated development area within the county. Also in Sparks, another colonia. That's primarily a family planning site. And then we just added sites in frontier rural counties, Hudspeth and Culberson counties. Each of those counties has about 3,000 people. Next slide. We have a wide range of program activities. We have the primary care, mainly staffed by family practice providers. We've got a little over 100 units of low and moderate income housing. Our early childhood development center is about 7 or 8 years old, sees about 70 kids a day. We have a transitional living center for homeless families with children, and we've also added a number of other program areas. The Microenterprise Development Project adds about 13 jobs in the community every quarter. Okay, next slide. Rachel, talk a little bit about how we got into the program.
Well, and that's actually where we're going to go next. If you could just hold on one sec. So what we're going to do now, now that we have a quick introduction from Lifelong and Project Vita, is we're just going to dig in a little bit more. Next slide, please. And we're just going to run through a few questions. And so, Bill, you're leading us in exactly to where we want to go. We're going to start with, how did your program start? And how do we start with you, Brenda? And if you could talk just a little bit about Lifelong. Next slide.
I'm waiting for the slide to come, but I'll start talking while it's coming up. So as I mentioned earlier, our first clinic of our 6 primary care clinics was started about 35 years ago by the Gray Panthers with a focus on providing social support services for the elderly to help them to be independent and to be able to continue to live at home. And so the core services were really psychosocial as opposed to medical. Most people coming into the clinic initially had other sources for medical care, but were not getting the support services that they needed, and their psychosocial issues were not being addressed. So that was really the beginning of our focus on working with folks around their psychosocial and behavioral health needs. And we've also had a historical focus on primary care for the disabled, homeless, and the elderly. And when you look at serving those populations, the driving issues are clearly psychosocial factors, and that's driving issues in terms of their health status, not just the medical issues. And we know that, as Lori mentioned earlier, that even if you were just looking at outcomes for primary care issues like diabetes, asthma, and hypertension, that if you do not address the behavioral issues, that the outcomes for those conditions are not particularly good. We've had a more recent focus on managing chronic disease, which has highlighted our need for behavioral interventions across our entire population. So we have refocused our efforts around behavioral health to look at integrating into the chronic disease that we're providing to our patients. Our CEO and medical director have supported integration of mental health professionals at all of our primary care sites, and we've hired licensed clinical social workers, psychologists, and psychiatrists as part of our care team, so that all of our primary care sites have those types of professionals on staff at their site. We really did start by providing a more traditional mental health model embedded in a primary care setting, and more recently we're transitioning to maintaining some of those traditional mental health services, but also looking at some of the more short-term interventions that are chronic disease focused and health psychology focused. Next slide. And over to you, Bill.
This is Rachel. I'm really glad to be with you all today. Our integrated healthcare program began with concerns that we had about chronic disease management. On top of that, we had a co-located counselor on board, but we still were seeing very high no-show rates, and we were not seeing a lot of improvement in the overall health of our patients. Through a grant from the Hawk Foundation for Mental Health, we were able to add the care manager function and form a collaborative with Mental Health and Mental Retardation Center that provided us with a psychiatrist 2 hours a week for case reviews and consultation with the care manager and our providers, and also with the family service organization who provides us with the on-site counselor. Family service, having that collaborative with them was also very beneficial because they have a long history of serving this community, and they often see the same population that we do. Through this grant, we incorporated the impact model for tracking our patients that were identified with depression and or anxiety. Next.
Thank you very much. You know, we started off when we were talking about the evidence base, we were talking about the impact model, and I know, you know, it's a model that's really been talked about a lot, and part of what we wanted to do is talk a little bit about the real-world implementation about that, and so I talked a little bit about that, but could you all then talk a little bit about your implementation of impact and what worked and didn't work? I think next slide, we could go to you guys, Rachel and Bill.
Okay. What worked for us was the ability to identify and treat behavioral health issues and other health issues simultaneously. Our patients' response to the team approach in their treatment was really positive. Attaining 100% buy-in from the staff and 100% cooperation from our partnering agencies really worked well for this model's success. The impact model is extremely user-friendly as it's easily adaptable to any clinic setting with its accessibility to the PCPs, to the psychiatrist, and to the care manager. The web-based registry that was provided to us through the Impact Implementation Center facilitates systematic follow-up with patients because it not only tracks the patient's progress, but it creates an at-a-glance graph of the progress and generates a reminder for scheduled follow-up, alerting the care manager if a patient has not been contacted. This helps us acquire a good adherence from the patients with their treatment.
It did take us about a year to ramp up our primary care providers to feel confident enough to prescribe the level of meds that were really needed.
Great. Thank you. Now over to Brenda. Could you talk a little bit about your experience? Because I know it's pretty different than Project Vita's.
Yeah, and just to start out, I want to say, although there are lots of pros and cons in our experience with Impact, is that I do think that by taking on Impact, that it really pushed our organization significantly further along in trying to really conceptualize how we wanted to do integrated care at our sites. And it was, I think, very useful to start with a program that had been researched, that had some support and some information really attached to it in order to have a structure to start doing a really focused integration. And so yes, we really, our attention really was heightened around integration of mental health. And I would say that we really saw an increase in staff involvement at all levels around integration issues. And that included our primary care providers, which are both MDs as well as mid-levels, our support staff, which included MAs in the front desk, and our administrators, as well as our IT. And what we're finding is that now going into the future, that integration is really much more on everybody's agenda when they're talking about issues and when we're developing our programs. It really promoted universal screening and the concept that screening was useful, and opened the eyes to providers who thought that they were pretty good at identifying mental health issues, that they really were not catching everybody who had a mental health condition, and I think particularly lower level depression. The program worked particularly well in our over 60 clinic because it was a model that was really developed for identifying depression in the older population. It really promoted our multidisciplinary planning and treatment and step care, and has a really terrific evaluation component, which really forces your practitioners to evaluate patient improvement as you're moving along, which is something in the mental health field that I don't think is typically done. Really stopping to assess whether the client has shown improvement based on the intervention, and reassessing what the intervention needs to be, whether you want to continue along the same path, whether you want to change the intervention to, for example, include medication or include a talk therapy or group therapy. For us, some of the cons, and I think cons is a little bit of a strong word, because I do think that this experience did help us overall in the long term to improve how we're doing integration. But this model was developed initially for and exclusively for depression. And the population that we serve does have a heavy burden of anxiety, PTSD, substance use, and domestic violence issues. And we found that this model wasn't perfect for really looking at all of those comorbidities, let alone the additional burden of having a physical health issue. It was also difficult for our behavioral health staff to keep up with the referrals. All of our clinics ended up having a waiting list, and so capacity to actually provide services is definitely an issue to be considered. We had an issue with our data collection, and having a standalone data set that was just for impact was not ideal. We have yet to adopt an electronic health record. We're hoping to be there within 2 years, but we have a lot of standalone data collection sets, and it's really burdensome. I don't think that we found that impact inherently promoted integration regarding chronic disease or other primary care issues, that we really needed to be very, very conscious of including those aspects in the care conferencing, and not just focusing on the depression and other mental health issues. And there was definitely some opinion on the part of staff that they felt that there was a lot of work, but that it didn't result in a large number of clients getting treatment, and that there were still plenty of folks who were missed who did need treatment, especially going back to those who did not have depression but had other mental health concerns.
Good. That's really helpful, and I know that we may have some good audience questions following up to ask you all about that, because I know people are pretty curious about impact. So I appreciate hearing from both Project Vita and Lifeline about your different experiences with that. Thank you. So given kind of where you guys have ended up, and having done worked on integration for a number of years now, I'd like for you guys to talk to us a little bit about what you consider to be the quote-unquote active ingredients of your current approach. We could start with you, Brenda.
Sure. I think to start with, definitely co-location of staff, and preferably having primary care and behavioral health staff sharing offices. The more actual physical contact and seeing each other on a day-to-day basis, we found the more that integration really gets promoted. So, it's better to have people in the same building than in separate buildings. It's better to have them on the same floor than 2 floors. It's best to have them actually have workspace in the same room, or in a situation where they're passing each other in the hallways and seeing each other regularly. We have regular multidisciplinary team meetings at all of our sites, which includes primary care, psychiatry, behavioral health. We're including now our clinical care coordinators who do panel management, and health educators. Having the capacity to do warm handoffs between the primary care and behavioral health providers is very helpful, because often what happens is the primary care provider, when they have the person in the office, they identify some kind of psychosocial issue that they want to get some assistance input in, some additional assessment, or they just want to be able to have the chance to introduce their patient to the behavioral health provider at that moment, and reinforce that this is part of their care plan, that it's not a separate department, it's not a separate service, that it's really integrated into what they are providing as part of the primary care experience at our clinic. Having as much flexibility as far as scheduling, interventions, drop-in, et cetera, is very, very helpful. We also use a lot of non-licensed staff, which is challenging in the world of California S2HC, where you can't bill for non-licensed staff. But we use case managers, we use clinical care assistants, We use MSWs, and those range from having high school diplomas but no bachelor's degree to having master's degrees. We definitely approach our work through a patient-centered approach and with a recovery focus. And one of the things that we're really trying to work into the integration of behavioral health into our chronic disease work is to really put front and center the patient's goal around management of their chronic disease, and having primary care and behavioral health use that as a jumping off point for treatment, for discussion with the client, for really assessing how things are going in both their disease management as well as their mental health status. We try and package our services as part of the primary care experience, partly to remove the stigma. Many of our patients won't go to a mental health center. There is a lot of stigma around receiving mental health services, and just the words that we use. We generally try not to call our mental health, licensed clinical social workers or psychologists necessarily mental health providers, because just the words mental health can turn people off, and they can say, no, I don't need mental health services, I don't have a mental health issue. But if it looks more like a support service or something that is being introduced as a way to help them with their primary care issues, then they're more likely to be open to receiving the service. We've also really been looking at behavioral health as a spectrum of care that includes health education, case management, social work therapy, and psychiatry and medication. And understanding that people move along that spectrum over time and may be receiving any number of those interventions at one point in time. A huge issue is training of and acceptance of integration by providers. And I could say that definitely at any point in time up till now, even though we've been doing this work for a long time, that there are providers who are much more champions of this work and others who would prefer just to go along doing things the way they've always done it and have not 100% bought into integration. And when you have multiple sites like we do, having 6 primary care sites, there's often variation across sites around the level of acceptance of integration. And then also being sure that we are not separating out substance use, that mental health, substance use, and physical health issues are being addressed simultaneously. And often when we talk, we're talking about integration as being integration of behavioral health and physical health. In the world of funding and policy, often substance use and mental health are still separated, and we're really trying to get away from separating out substance use. So substance use is integrated into our package of integrated services.
Good. Thank you, Brenda. Next, Bill or Rachel, could you talk about your active ingredients?
Sure, I'd be happy to. I think we share a lot of the same ingredients, but some of them that I wanted to point out. Starting with a care manager, the care manager is just a super important component of this, because the care manager pretty much is the one that brings everyone together, gets everyone talking to each other, and is the person that helps the patient to feel embraced by everybody else on the team. Care managers act like the eyes and ears of the doctors, and the voice of the patient in wanting to get the information back, the feedback to the doctors. The care manager is important in educating the patient about what depression is, what anxiety is, and really destigmatizing those so that they can feel better about getting treatment for whatever it is that they're going through. I think what makes this program work is the in-house collaboration, our accessibility to the consulting psychiatrist, and the educational component that he brings even to our providers. Our trained promotora team that collaborates closely with the behavioral health staff to address physical and nutritional needs so that our patients are treated holistically. That's a real important component because we're both working on our ends with the patient, and the patient really feels embraced. Certainly the cognitive behavior therapy that is used in counseling, whether individually or in a group setting, to help our patients lower their levels of depression and anxiety. Included in this mix is the web-based patient registry, because that assists the care manager in tracking the patients to do timely follow-ups and support patients in adhering to their treatment and medication management. One of the issues I think that come up and what really doesn't work well is the comorbid conditions such as substance abuse and chronic pain issues that are statistically not going to show much improvement in those patients' anxiety levels. But the fact that we're still able to track them through this patient registry system is amazing, because if we didn't have that, they would go by the wayside. So that's been a really, really important ingredient in our treatment.
Very good. Thank you, Rachel. You know, one thing I'd like for you guys to talk about next, I think is really important for people to hear about, is what is the difference between the kinds of services you all are providing now and what you would call traditional mental health services. So if you were in a specialty mental health clinic, the kinds of care you might get there versus what mental health services may look like in a primary care setting. Rachel, could you talk some about that, or Bill?
Sure, I'll be happy to. Our patients see a visit to our clinics as a one-stop shop experience, because often many of their issues can be taken care of or at least addressed with one clinic visit. They're not working with referrals or difficulties in getting back into the system. Our patients tend to be very protective of their privacy and don't establish trust relationships very easily, and outside agency referrals often aren't effective. With our integrated healthcare program, they know all the players on their treatment team, and they're comfortable in knowing that no matter who they come to see, we're all on the same page in regard to their treatment. The manner in which we address mental health treatment is geared towards teaching the patient life management skills rather than the normal coping mechanisms that work for a little while until they go back into their environment and then have the problems again. The materials that we use are culturally adapted to meet the educational level of the patient while addressing stigma-related concerns that might prevent the patient from seeking help. We use cognitive behavior as our treatment modality in working with the individuals and in the groups, because it's short-term, it's educational in nature, and the patients respond well to it. Patients with more severe mental health problems are referred out to EPMHMR or to the Family Service Counseling Agency for much more intensive therapy.
There are a couple elements that go into this too. We are in a massive shortage area for behavioral health care providers. There's no way we can do clinical psychologists. We're having even a problem getting LMSWs in place. Secondly, in Texas, we are not considered to be an authorized provider for the core diagnoses of bipolar, schizophrenia, major depression. Psychosocial rehab is only funded through mental health authority entities. So we're in a position of how do you start with a primary care program and migrate into dealing with mental health issues. We don't have a mental health team as such. So we've never been traditional mental health.
Very good. Thank you, Bill and Rachel. Brenda, you want to talk about kind of traditional mental health services at Lifelong?
Sure, and I think this is where there's a significant difference between what Project Vita is able to do and what we do, because we have provided and continue to provide traditional mental health services in terms of having psychiatry, medication management, psychotherapy, and long-term treatment available at all of our primary care sites. And it really developed because there was such a shortage in the community, both for those who were covered by Medi-Cal but were not sick enough to qualify for county mental health services, as well as the uninsured who have really no access to mental health services through the county unless they end up being hospitalized. But we're also providing short-term interventions with a focus on people learning life skills and disease management skills with a behavioral bent to it. Shorter visits, so we have many more half-hour visits now than we used to. We definitely link with case management. Our focus is leaning more towards working with people with chronic physical health conditions like diabetes and hypertension. And we definitely use stages of change and motivation focus with our clients. I also just want to mention that we do a fair number of groups at most of our primary care sites.
Great. Thanks very much, Brenda. You know, a lot of times I think people fail to think about the prevention and early intervention issues here, and that's part of what I wanted to talk about in my overview. Is I think one of the key things with integrated healthcare is that if you see mostly mild to moderate folks, and I know it's not just that, but if you see mostly folks with mild to moderate mental health problems in primary care, there really is an opportunity to intervene early and to actually prevent mental health problems altogether, or to prevent them from getting worse. Could you all talk a little bit about how your programs address prevention and early intervention? Brenda, could you start?
Sure. So we're actually right now, as an outgrowth of IMPACT, we're piloting an annual screening tool for all adult diabetics to identify depression, PTSD, anxiety, and substance use, and hoping to pick up folks who haven't presented with a quote-unquote mental health problem, but where there's an underlying issue that's often connected to that chronic disease. And we're also really working with primary care staff and using some of our data to identify when physical symptoms are potential signs of an early onset of a mental health issue. One of the interesting things that's just recently come up in our pilot using the screening tool with diabetics is that we're seeing a trend where we think we might be able to really not even need to use an initial screening tool to refer for a more in-depth assessment, but just potentially use the hemoglobin A1C levels. And because what we're finding is that the folks who end up getting screened positive and then screened positive with an assessment and get sent to a mental health professional are those who are having high hemoglobin A1C rates. So it's interesting to start comparing the primary care labs and symptoms to the mental health assessments and screening tools. We're referring primary care patients to behavioral health staff when there are changes in health status and when it seems like behavioral issues are impacting health, or when there needs to be additional psychosocial support. So sometimes we've got somebody, for example, who has diabetes and they're going along and everything is really going quite well, and then there seems to be kind of a blip in their care and things seem to start to fall apart. And at that point, the primary care provider, the person may not be screened, it may not be at the time of their annual screening, but it's a red flag to the primary care provider to say, let's see what's going on with this person in their life and whether they might be able to get some helpful support from behavioral health staff and intervene early before things get out of control. And often we see that case management is the door through which mental health issues are identified and through which intervention is provided. So our primary care patients often don't identify as having a mental health concern, but they often identify as having immediate needs as far as resources, whether it's housing, food, other types of resource needs. And what we find is that once a relationship is developed with a case manager or social worker, and our therapists often do case management as well, that other issues surface and that we've developed a trusting relationship with the person at that time, and then we're able to add on a more therapeutic intervention.
Great, thank you. How about Bill, Rachel, what about prevention early intervention at Project Vita?
Well, at Project Vita, we screen every patient every time they come to the clinic for services. This is just part of the triage. The patients already know that just as they're going to have their height, weight, blood pressure checked, they're going to fill out the PHQ-9 health screener for the depression and the OASIS screener for their anxiety levels. So that's a normal part of the triage. We also provide orientation to individuals and families that we feel are at risk using the cognitive behavior therapy as a method of them recognizing how their thoughts play into the cycle of depression and how they exacerbate their anxiety. Our care managers are strategically located within the clinic, close to the patient care areas, so that there can be a warm handoff by the providers and or support staff if a patient is identified with depression or anxiety. Another thing that we do is that we sponsor frequent health fairs that address the physical, the emotional, and the nutritional health issues that our community members may be struggling with, and we offer them assistance. One of the things that we tried out that was a little bit different going into our diabetic support groups and providing some CBT classes. The patients didn't really know that it was CBT that was being used with them. They thought, you know, we call them classes to just elevate your mood, and we call them whatever was necessary to attract the patients to staying and listening to us. It was the curriculum that we use is the curriculum that was developed by the University of San Francisco Medical Center. Some docs over there developed this culturally sensitive curriculum to address patients with low levels of education and understanding, low socioeconomic status, and it just really seemed to fit with our group. This made it really, really easy for us to access those patients that might not otherwise come in for counseling if we were to try to catch them. So that's one of the ways that we work very closely with the promotoras, with our health educators, so that, you know, we catch those patients when they're in there for their support groups. It's worked out really, really well.
Excellent. Well, and that's a great segue into the next question, which is, I think a lot of times people are looking at how to use non-licensed folks, such as promotoras, in helping to do this kind of services. Starting with you all at Project Vita, could you talk a little bit about the role of such folks in your service delivery? And again, we're actually, you know, just in the interest of time, if you could keep your answers pretty short, that'd be great.
Absolutely. Well, our Diabetes Empowerment Education Program uses, again, the CBT methodology in addressing the struggles of our patients in maintaining healthy lifestyles. Through outreach programs and educational support groups, our promotoras, they incorporate educational materials about depression and anxiety in their curriculum. They lead group activities for secondary prevention that often include our care manager and or the counselor as presenters. So the care managers, although we are not licensed providers in an FQHC setting, I think having the care manager working very closely with the promotoras, we pretty much do very, very similar work. So it works out very well for us.
Thank you.
How's that? Is that short enough for you, Lori?
Lovely. Thank you, Rachel. How about lifelong? What role do non-licensed folks play?
So our MAs help with the screening and facilitating warm handoffs. Case managers provide intensive service for our highest risk and highest need clients and do outreach assessment. They provide education. They broker services. They provide harm reduction interventions. We have a relatively new type of staff called clinical care assistants who are our panel managers, and they facilitate referrals, education, and support. And we also have health educators who are not licensed and who provide both group and individual services focused on behavior change and chronic disease. And then we also use behavioral health students in most of our clinics, both MSW students from UC Berkeley as well as psychology students from a local school. And for those of you in urban areas, it's a tremendous untapped resource and one that can really stretch your capacity to serve folks, especially when you're trying to really use your licensed folks for as much billable time as possible. Our care managers actually in most of our clinics are LCSWs, and we do bill for their time under FQHC in California. Also, just an aside, this is not about licensed folks, but I do want to say that having psychiatrists in-house is a wonderful way to expand the capacity of your primary care providers to do medication management and really increase their ability and feeling confident that they're doing right by their patients.
That's a great point, and I know the Project Vita folks have definitely seen that as well. You know, one thing that I think is really nice, especially thinking about folks in California wanting to do these kinds of approaches, is the fact that you guys at Lifelong and you all at Project Vita have very diverse populations that you're serving. Could you all talk a little bit about how you tailor your services to the diversity of your patient population? Brenda, could you start?
I think Project Vita's slide is first.
Oh, Project Vita, sorry.
Well, here we are.
Okay. Our population is about 99% Hispanic. Therefore, our providers are bilingual, and many of our providers are from the same communities that we serve, so they know the population well. Our promotoras provide culturally and linguistically appropriate services that are culturally adapted to meet the educational level of understanding and the psychosocial needs of our patients. The counseling and CBT group classes that I mentioned before are also culturally adapted to the populations that are participating. And through the community congress that we mentioned earlier, we gain an awareness as to whether our perspective matches the community's perspective regarding how their needs are being addressed. And I think in this way we serve them the best, because the programs that we have at Project Vita are tailor-made for the populations that we serve, because they're services that they have themselves requested at our community congresses, and they've had some say-so in how they're built.
Good, thank you. How about you, Brenda?
Well, I think community health centers at their core came out of the community and were developed in response to the culture of the people living in the communities. And I think that it's one of the reasons why providing behavioral health at community health centers is such a wonderful thing, because it provides a non-threatening entry point for mental health services that really does address a lot of the cultural issues and a lot of the stigma. We, as much as possible, do try to hire a diverse staff, both in terms of language, culture, approach, experience, and perspective. And I think, above all, we really try to do client-centered care, which promotes attention to the individual person's perspective and needs and culture. We find that groups are a really interesting and effective way to address a lot of different issues that relate to culture. And using non-licensed staff also expands our capacity to hire a diverse staff. We find it difficult sometimes to hire licensed folks who are really reflective of our population, but it's much easier to recruit non-licensed folks who reflect our population.
Good, thank you, Brenda. Now kind of wrapping things up a bit, a couple of questions to kind of think back and reflect on how you all are right now. Starting off, what are the biggest challenges that you face at present? And Dr. Vita, why don't we start with you guys?
Yeah, there's the stuff up on the screen, and then there's the stuff I was making notes about. One of our challenges, we've been using electronic medical records for a number of years. The registry functions differently than the EMR. The EMR is basically a flat file. You go into a patient, see what's going on with that patient, close that patient, go on to the next one. The registry extracts data and charts it so you can see how a provider is doing in managing care across their panel. You can't do that with our current EMR, and we're trying to work with our provider to do that. So one challenge is to get to the point where we can have one electronic system that deals both with the in-depth information and then pulls out some of those data points and lets us see some trends and some directions. I understand that the population that we're talking to is mainly California. We are, in a way, the flip of California and Texas on the issue of funding. General revenue from the state goes only to local mental health authorities. And in order for us to take our next step, which is to flip the impact model into working with people with serious and persistent mental illness who are getting zip in the way of primary care, we've got to find a way to integrate into that system. We've got a very supportive local mental health authority. We're scheduled for a phone call after a year and a half of asking with the state on June 16th. So we're going to see if we're moving forward on that one or not. New providers coming in don't really, sometimes they don't get it. Sometimes they want to do their thing and leave me alone. And so there's a acculturation process. And the base of the care manager is their personality. It's so much an issue of them wanting to be wrapping around these folks that finding the right person to fit as we expand is a challenge.
Thank you, Bill. Moving on to Brenda.
Yeah, I think there are lots of challenges, and building on what Bill was just talking in terms of staff, one of our challenges has been that because we have provided traditional mental health services in our setting, changing staff roles are very challenging for people who've been doing it one way for a long time, and moving from a traditional 50-minute therapy session to a 20 to 30-minute session, focusing on chronic disease versus a mental health condition. Those are all things that I think have really challenged a lot of our staff. We also have a lot of pressure to increase our visits, and figuring out how to do integration within that that pressure is something that we've been challenged by. Our financing structure in California as an F2HC has limits to it. Unlike in the mental health world, we don't get reimbursement for groups. We can't get reimbursement for services provided by MSPs or MSWs. We don't get reimbursements for same-day visits for primary care and mental health, and we don't get reimbursed for any kind of telephone support. We'd like to really see the mental health and primary care financing become more similar and really support the best practices models that we see coming out of mental health, which does include groups and using a more wide variety of professionals. It's also challenging to evaluate our impact of integrated services. It's a lot easier to track a hemoglobin A1C or a blood pressure than it is to track improvement in behavioral health, especially when our ultimate goal is not to get rid of a condition. It's really to help people learn to function well and to have good quality of life, and we need to be really exploring how to measure that and see where we're making improvement. It takes a lot of energy to create efficient screening and triage processes. Getting all the details down, implementation of new programs takes a long time. As I mentioned before, it is hard for us to recruit mental health professionals from diverse communities. While there are probably more therapists per capita in the Bay Area than anywhere else, maybe in the world, finding folks who are African American, Latino, and from other diverse communities who are trained as professionals and also want to work in a community health center is very challenging. Definitely our demand for services exceeds capacity, especially in the uninsured population, and we find that we don't have as much support services for our extremely high-risk clients who require very intensive wraparound services as we would like to have, particularly case management.
Great, thank you. And then
one more thing is that we're finding that a lot of the IT tools, as we look at electronic health records, that IT tools are not developed for the behavioral health provider or behavioral health services in mind. We're constantly having to adapt when we our IT tools, whether it's a disease management tool or an electronic health record.
Very good, thank you. And then just real briefly, and so we have time for audience questions, could you all talk about some of your key lessons learned? Brenda, could you start?
So primarily, I think being very deliberate and also patient with culture change, which is what really switching to an integrated model entails. It takes a long time, and you're going to meet resistance along the way in different ways, and you have to be prepared for that. I think it's important, and we found it tremendously useful to engage leadership staff in our integration efforts, and to have our CEO and our chief medical officer and our operations officer really understand what it means to integrate and be behind that. We have really worked into our hiring for both primary care staff as well as our behavioral health staff questions and focus on integration as a key component of what it will be expected of them. And I think building that into your recruitment and interview process is important. And ongoing training is particularly important to get people not only the skills but the buy-in into the model. And then finally, building integration into our strategic planning efforts and making sure that it's a critical element in our clinical priorities, and developing the tools needed to support that on the ground are also important elements.
Great, that's very helpful. Thank you. Moving on Project Vita, folks.
Okay, well, we learned that providers and support staff champions are critical to realize and stimulate the team concept. Trust must be established among the patients, the providers, the psychiatrist, the counselor, and the care manager. Once the provider witnesses the benefits of working collaboratively, Their testimonials often serve to increase comfort levels of the less invested providers. We also learned that the care manager's personality, as Bill was saying earlier, can be a determining factor in the cohesiveness of the team. The collaborative care approach reduces stigma by presenting depression and or anxiety to the patient as a health issue, much like diabetes or hypertension, that are treatable and controllable with appropriate treatment by their provider and commitment by the patient. Certainly comorbid conditions have to be addressed or it's just not going to work. And creative partnerships that are patient-centered surely make for a more successful mode.
Great. Wonderful. Thank you so much. This is a very nice discussion. I appreciate all of your thoughtful tips and information that you provided. For those of you out there wondering where you can learn more, the next slide shows a number of key resources that been compiling, and I know a lot of people find pretty helpful. I wanted to particularly point out the National Council for Community Behavioral Health Care. They have a really excellent listserv where you can post specific questions about integration, and they have a wonderful array of resources on their website. Also, the AIM Center, which I talked about, it looks like a couple people tried to log on to that and had problems that that is the correct URL, so maybe just need to try again. I really cannot say enough good things about the IBHP, the Integrated Behavioral Health Project website. There, it's a California-based program. Barb Lurie, who's there, who's the co-director of that, did an amazing job putting together a toolkit on integration that I encourage all of you to look at. It has amazing resources in terms of templates for MOUs, job descriptions, et cetera. It's excellent. And if you're looking for a good resource, kind of a basic guide that outlines some of the materials that we talked about today, making the case for integration, kind of the evidence base and all that, you might be interested in the Hogg Foundation's resource guide that was put out a couple of years ago. So I have that on there again as well. So finally, we have some time for audience questions, and I know it looks like a bunch of you have written in. Thank you so much for that. The first question, I think, is a really important one. If both Lifelong and Project Vita could address this briefly. The question was, why would a PCP, why would a primary care provider want to take this on? Why would they want to do what sounds like just a lot of extra work?
Our providers experienced it as diminishing their workload. They walk in and somebody is having a clear depressive episode. What they were doing before was they were stuck in the exam room for half an hour, 45 minutes on what was scheduled to be a 20-minute visit. Now there's a place to take that person and do a warm handoff and not cripple the provider by either having to stay in the room or feeling like a real jerk for walking out.
I would totally agree. I think our providers don't feel like it's extra work, but that they're actually able to more effectively treat their patients and that they have support from other staff. And we've tried to set up our screening and assessment process so that there's not a whole lot of extra administrative work on the part of the primary care provider. I think it is important also just to make sure that, when primary care providers get feedback from the behavioral health staff about the positive impact of their interactions with the primary care patient, that goes a long way towards the providers learning what the impact of their making referrals is.
Great point. Very good. Now we have a question for Brenda at Lifelong. A question about funding. The question is, where is funding coming from for the many services that you're providing, and what are you all? Where are the chronically mentally ill folks in the population receiving mental health services?
Lori, I had a really hard time hearing you, that last part of the question.
Great, let me repeat that. So the question is, where is the funding coming from for the many services that are being provided? And could you talk very briefly, because I know you already addressed this, about where services for the chronically mentally ill folks in your population are getting services?
So the funding, it's a combination of billing for Medi-Cal, Medicare, as well as we have a lot of grants, particularly for our case management programs, and those grants come from a variety of funders, both federal, city, county, as well as private foundations. We really try and structure the way we provide services so that the mix of services being provided by the licensed folks who can bill helps to support the non-licensed staff. But it doesn't go quite far enough. If we didn't have our foundation and other grant funding, we wouldn't be able to do it. And we actually, if I understand the question correctly, we are chronically mentally ill patients receive services from us often, and sometimes from the county mental health department. So it's a mixture. And if they're uninsured, it's very difficult for them to receive services from the county, and so we tend to hang on to those folks. If they do have Medi-Cal and they qualify for services with county mental health, then we will definitely try and work to help them get into care there. But we hang on to a lot of folks. We see a lot of folks with bipolar disorder, schizophrenia, major depression.
Very good. And a quick follow-up on this, I think you were briefly touching on this. The question was, how are you reimbursed for non-licensed staff?
You know, some of the non-licensed staff it's built into our FQHC rate because it's an allowable expense. Others are funded by grants. And we've had an ongoing disagreement with the state of California around whether case management expenses can be built into our FQHC negotiated rate, and so far we haven't won that argument. So that's an ongoing issue for us.
Very good, thank you. A question for both of y'all. What role can specialty substance abuse providers play in an integrated model? Should they collaborate with primary care?
Bill, do you want to answer?
Brenda, do you want to
I
take
would
that?
just, yeah, give it over to California. We're not there yet.
Okay. I think, you know, I've been involved in some discussions about this, and as primary care providers, it's one of the areas I think that we've been lagging. But there are possibilities for co-location of specialty substance abuse providers, and there are some clinics in the state that are doing that and finding that it's a tremendous benefit to them, where they're working side by side with substance abuse providers who come to their clinic, you know, anywhere from 2 to 5 days a week, and are available to do warm handoffs from either primary care or mental health to substance use, and to be part of the care coordination team.
Very good, thank you. The next question I think also applies to both of y'all, but especially, you know, as a California provider, if you could address this, Brenda. Who provides the psychiatrist for psychiatric consult at your clinic? Any suggestions for how to do this when the FQHC does not have a psychiatrist on staff?
We have in the past had an arrangement with our county mental health program. It was for a very specific project that we were doing, and they co-located a psychiatrist at our clinic. I think, you know, similar to what Project Vita has, and then our county also has a phone line where folks primary care providers can call and get consults, although it's not used tremendously. You know, we've recruited and hired psychiatrists. It's very challenging, especially given what we can afford to pay them, and as compared to, say, the criminal justice system and what psychiatrists are being paid by that system. So I think, you know, having some conversations with the agencies that do have psychiatrists on staff, and seeing if there is a way to even get a minimal number of hours for consults so that your primary care providers can get the kind of support that they need. That's one route.
We're setting up telemedicine for our psychiatric consultant as well, particularly in our frontier counties. There's no way we can move him out there.
Very good, thank you. This next question is for the Project Vita folks. I'm going to paraphrase a little bit, but basically the question is saying, so if you refer away all the folks with severe mental health issues like bipolar disorder and schizophrenia, and you have and you try to refer out people with substance use issues and pain management issues, who's left? Who do you end up seeing, and aren't those folks that would just get better anyway?
We could tell a lot of stories. There are 30-year-old male diabetic who was convinced that his diabetes was sent by God, and so he was going to go in for what's it called?
A dialysis.
Dialysis treatment. I mean, we are not a specialty clinic. and specialty issues are beyond us. But the garden variety population has depression and has anxiety issues that severely affects their ability to handle their chronic physical disease. That's a lot of folk, and that's plenty for us right now until we get bigger and stronger.
Bill, could you talk, do you have any sense of what percentage of your folks have the anxiety or depression issues?
What are your numbers?
Well, we have my own ongoing registry list stands at about 112 patients that I'm tracking at any given time. So we've got quite a bit. And if you've got I'd say probably 80% of them have both the depression and the anxiety that they're having to deal with. And if you think that that there's the other issues for our population, the socioeconomic struggles that they're dealing with and everything else, having this for them is just it's just a godsend for them.
112 would be a point in time. We're looking probably at about 10%, and we've got about maybe 10,000 people in our total unduplicated individuals. So they're moving those 112 through over an 8 to 12 week period on a constant basis.
Thank you. That's very helpful. Well, thank you to all of our panelists for such a stimulating discussion of your different approaches to addressing mental health issues in primary care. I'm afraid we're now out of time and have to leave things here for today. Our thanks to all of you for attending this fourth webinar in our 6-part webinar series, Integrating Primary Care, Mental Health, and Substance Use Services. Your questions will be posted as FAQs on the CIMH website at the link you see on your screen. If we can move to the next slide, that shows the last, there we go. Great, thank you. I would also like to thank our outstanding panelists for this excellent session on addressing mental health issues in primary care. Thank you so much for your time and for sharing your valuable insights and experience. Just so that you all know out there in the audience, this webinar was recorded and will be posted on the CIMH Integration Initiative's webpage at the link you see on your screen. The slides will also be posted on the website, so you can print them out and share them with your colleagues. And they were emailed to you earlier with a reminder for this webinar. Our next webinar is next Thursday, June 10th, and we'll focus on bridging differences in the cultures of primary care, mental health, and substance use. To view the CIMH webinar schedule or to register for a future webinar, please go to the link you see on your screen. You may want to print this PowerPoint slide for future reference. Please note that you must register online for each webinar you wish to attend. Again, thank you all and have a great afternoon.